help in elevation of the larynx during swallowing, and those are the stylopharyngeus, salpingopharyngeus, and the most important of them is the palatopharyngeus muscle. Okay, so those are the three vertical muscles, but the more important are the constrictors. Okay, so 6 muscles contributing to the wall. We spoke about them. Now we go into more details within the cavity of the pharynx. What you're gonna see inside the pharynx. First, we will go to the nasopharynx. You know that the pharynx, since it extends from the base of the skull down to the level of C6, it's divided into 3 parts. We say nasopharynx behind the nose, oropharynx behind the mouth, laryngopharynx behind the larynx. Okay? We will go over each one. If we look to the nasopharynx now, how would I distinguish the border between the nasal cavity and the nasopharynx? You distinguish it simply by these bony shelves. There are bony shelves, we call them conchi in the nasal cavity. Okay, concha is the singular, and concha means shelf, rough, because they go down like bony shelves. So, when you look to the conchi, the posterior border of each concha here, this posterior border of the conchi determines the end of the nasal cavity. So, all of this is the nasal cavity. Behind the conchi, you will get into the pharynx. So, this is the nasopharynx. Clear? So when we speak in a real cadaver, in a sagittal view of the head, you see these are the conchi, superior, middle, inferior. This is the nasal cavity. Here, the nasal cavity ends, and all this space here is the nasopharynx. What you're going to see in the nasopharynx? First, 2 important lymphoid organs, okay? Lymphatic aggregations, okay? One is located in the roof. You see this one here? There's a lymphoid nodules, a lymphatic nodules aggregated here in the roof of the nasopharynx. This is the largest tonsil. Okay, in your body we call it the pharyngeal tonsil or the adenoid. Okay, the adenoid, adenos, which means like a gland. So this is the adenoid or the pharyngeal tonsil in the roof of the nasopharynx. If you go down in the lateral wall of the nasopharynx, you will see there is an opening here in the nasopharynx. This opening is for a tube that communicates nasopharynx with the middle ear, okay, more laterally. This is called the auditory tube or Eustachian tube, okay, auditory or Eustachian tube. Now, at the upper border of Eustachian tube, there is a small elevation. You see it here? This is called tubal elevation here, okay, in the ground here. This is the auditory tube. This here is the tubal elevation. The tubal elevation mainly happened because of what? Because of the end, the medial end of the tube pushing the mucosa. But however, another contribution for this is because of aggregation of another lymphatic nodules, smaller aggregation of lymphatic nodules around the opening of the tube here. So if you bring the scalpel and cut the mucosa from here, you will see some lymphatic nodules. These nodules, we refer to them as the tubal tonsil because they surround the opening of the auditory tube. Tubal tonsil. Okay, so we have 2 kinds of tonsils in the nasopharynx. In the roof, we have one pharyngeal tonsil, the adenoid. On the lateral wall, we have 2, right and left tubal tonsils. Okay, so we have tubal elevation, tubal tonsils, opening of the auditory tube, and from the auditory tube, inferior end, you see there is another fold of mucosa here. You see this fold of mucosa? It's more prominent here. This fold is containing a small bundle of muscle fibers. This is the fold which we call it salpingopharyngeal fold. Why we call it salpingopharyngeal fold? Because it is a fold happened because of salpingopharyngeus muscle that descends from the auditory tube down and blends with the palatopharyngeus muscle. Okay, the palatopharyngeus muscle, one of the muscles of the pharynx. So, the posterior to the nasal cavity, you will see the nasopharynx. It's located above this structure here, the soft palate, yes. This junction between hard and soft palate is the border between oral cavity and pharynx. The soft palate is actually separating nasopharynx above from oropharynx below, yes. So this is here the soft palate. So it's located above the soft palate. It's lined by what kind of epithelium there? Respiratory epithelium, the pseudostratified columnar ciliated. Okay, so it's a continuation of respiratory epithelium. It contains auditory tubes, as you see them. They open where? On the lateral wall of of the nasopharynx, on the lateral wall. There is tubal tonsils covered by the elevation here, aggregation of lymphatic nodules around auditory tube, okay? And that's why you see the tubal elevation here. So there is a tubal elevation and pharyngeal fold. And lastly, the pharyngeal tonsil in the submucosa of the roof. You see this gland here, or this structure? In the roof of the nasopharynx. It's not a gland. In the oropharynx now, the oropharynx is located posterior to the oral cavity, opens to it through oropharyngeal isthmus. We spoke about it in the previous lecture. It's located between the soft palate superiorly and this is the oropharynx. You see palatoglussal fold because of palatoglussous muscle. This is the border, mouth, oropharynx. So this is the border of the oropharynx. So the roof of the oropharynx is the soft palate, the floor, posterior third of the tongue, the pharyngeal part of the tongue. It's between the soft palate and the posterior part of the tongue. At the level of which vertebra is this? شوفوا إلها دنس، إلها odontoid process. It has a tooth. C2, C3. This is the oropharynx. C2, C3. Okay. Nasopharynx C1, C2. Oropharynx C2, C3. C4, 5, and 6 are the level is the level for laryngopharynx. Okay. Remember these levels. So at the level of C2, C3, the floor now is made by the posterior third of the tongue. We said, and this depression here. This fossa, we call it vallicula. Vallicula, valus in Latin, from the Latin word valus, which means fossa, hofra. Okay? Because it's a depression here between the tongue and epiglottis, okay? Which is a cartilage of the larynx. So this is the vallicula here. It contains, what's the most important thing in the oropharynx? You will see in the floor, of course, the lingual tonsil, which is the posterior third of the tongue. But at the lateral walls, you will see the palatine tonsils. Palatine tonsils are resting on the tonsillar bed. We said in the previous lecture how you distinguish the tonsillar bed by two folds. Anterior, you will see palatoglussal fold. Posteriorly, the palatopharyngeal fold. For palatoglussous muscle, palatopharyngeal muscle. In between them, you will see the palatine tonsil resting. Now here, you see this muscle here? It's a circular muscle that goes like this. It's a muscle. This is the wall of the pharynx. The wall of the pharynx is made by the constrictor muscles. Okay? This is the superior constrictor muscle. It goes like this in a 3-dimension and turn around to go anterior like this. So as it turns like this again, the palatine tonsil is resting over it. Okay, over the superior constrictor muscle of the pharynx. Okay, and that's why when you look here, oropharyngeal isthmus and vallicula. This is the vallicula you see between epiglottis and tongue. This is within the tongue. We call it sulcus terminalis. Distinguish between them. Okay, sulcus terminalis and vallicula. Relations of palatine tonsils anteriorly. This is important for the clinical examination if you want to find them. Again, I am emphasizing the same point. Anteriorly is this fold. You answer it. Posteriorly this fold. Superiorly this structure. Inferiorly this. Yes. Medially inside. It's the cavity of the oropharynx, the space, the cavity of the oropharynx. Laterally, it's resting on which muscle? Superior constrictor of the pharynx. Okay. Something important related to these tonsils is tonsillitis and tonsillectomy. You know that tonsillitis is inflammation of the tonsils. Any kind of tonsils, tubal tonsils, lingual, pharyngeal, or palatine. But since the most common kind of tonsils to be inflamed is the palatine tonsil, okay? That's why tonsillitis generally in the clinics referring to the inflammation of palatine tonsils, okay? But more scientifically speaking, you have to call it palatine tonsillitis, okay? Tubal tonsillitis. But in general, they refer to it tonsillitis as the inflammation of the palatine tonsils. Inflammation of the pharyngeal tonsil, the adenoid, we refer to it as adenoiditis. Okay, the adenoiditis. Tonsillitis, the inflammation can be of two episodes, whether acute or chronic. The acute between 1 to 2 weeks at most. Usually it lasts just 6 days. Okay, 1 to 2 weeks, the acute. The chronic can last 4 months. What's the difference between the acute inflammation of the palatine tonsils and the chronic one? Yes, the cause. So, the difference mainly, in the acute mainly, it is a viral infection, okay, which lasts usually for 6 to 7 days. It's a viral infection, like Epstein-Barr virus, okay? In the chronic one, which lasts for longer periods of time, it is bacterial, okay, infection, okay? And that's always the difference between the acute and the bacterial. Now, the proper diagnosis, to make a proper diagnosis, you need to take a swab, yes, and make culture, okay? However, since it's very expensive, especially in developing countries, okay, and takes longer time, what they do, the clinicians usually just quickly prescribe antibiotics to treat. Okay? Because we know, if it's viral, the antibiotics will have nothing. What do you give if it's viral? NSAIDs, non-steroidal anti-inflammatories, okay? Paracetamol, whatever. If it's a chronic bacterial infection, now you have to give antibiotics, okay? But to be more in the clinic, just a hint for you, if you find the tonsils inflamed with a pus over them, more whitish, this indicates a bacterial infection. If you find them swelled, okay, but they are very reddish in color, okay, more reddish in color, this will indicate a viral infection, okay, because taking a swab and it will be very expensive. However, if it's a bacterial, they will describe antibiotics. What's the antibiotic of choice? Amoxicillin, yes. If it is allergic to penicillin, erythromycin. In developing countries where antibiotics are used a lot and there is a resistance, usually amoxicillin, especially in Jordan, for example, will not make that big difference. So what's a stronger if the episode was very severe? What's the second choice? Stronger antibiotic? Yes. For upper respiratory tract infections may be used, but it can help in tonsillitis. Azithromycin. Okay? You will study it in pharmacology, however. So, now, recently, the ENT surgeons developed something called tonsillectomy, removal of the palatine tonsils. Okay? Why? To get rid of continuous inflammation, okay, of the tonsils. So the rationale, be aware here. There is a rationale and there is an indication. The rationale why we have tonsillectomy, why we remove them, okay, because of the recurrent tonsillitis. Continuously, the patient suffering from tonsillitis, which will be interfering with his daily routine life, okay. He can't go to work, he can't study well, whatever, if he's a student. So there is continuous inflammation in these tonsils. That's the rationale. But the indication, not any person can undergo tonsillectomy. There is an indication. The basic one, now each association is changing, but the basic one is that for tonsillectomy, the patient should suffer at least 7 times of tonsillitis within 1 year. Okay? So if he had an episode of tonsillitis 7 times per year, okay, for 1 year, okay, within 1 year, that will be an indication to undergo tonsillectomy. Otherwise, if he had 5 episodes per year for 2 years, so within 2 years, around 10 times or more, that will be an indication for tonsillectomy, or 3 times per year for 3 years. Within 3 years, 3 times per year, that will be an indication. So the rationale why we undergo tonsillectomy is the recurrent tonsillitis. What's the indication? 7 times a year for 1 year, 5 times a year for 2 years, or 3 times a year for 3 years. Okay? This you can read this argument, but now because of many reasons and the ease of the operation, سهولتها, can done even the patient go home in the same day. Doesn't take more than 1.5 hours. Okay? So that's why they undergo tonsillectomy, and this debate has almost been getting what? Lower and lower. Okay? I'll show you the video, an explanation video for tonsillectomy, and I'll show you a real operation of tonsillectomy, and we will comment on them. I'm not sure if this is...
located on either side of the back of your throat. Normally, your tonsils play an infection-fighting role by aiding in the destruction of harmful bacteria and other germs that enter your body through your nose and mouth. The adenoids, located above and behind the soft palate, play a similar role. The tonsils often become enlarged and inflamed when fighting off an infection. This is a condition called tonsillitis. Tonsillitis may be associated with fever, sore throat, painful swallowing, and swelling of the lymph nodes in the front of the neck.
Painful swallowing, okay, and swelling of the lymph nodes.
It is most commonly diagnosed in children, but can be seen in some adults as well. While there are a number of indications for tonsillectomy, the most common is chronic or recurrent tonsillitis. Chronic inflammation of the adenoids, often due to allergies, may cause blockage of the eustachian tubes, increasing the risk of middle ear infections and associated hearing loss. An adenoidectomy is the surgical removal of the adenoids. Tonsillectomies and adenoidectomies are often done at the same time. When you arrive at the hospital for your procedure, an intravenous line will be started and you may be given a sedative to help you relax. Most cases are done under general anesthesia.
So first the sedative, then we put them under general anesthesia. What does general anesthesia indicate? Now, what should be the next step? Intubation.
It will put you to sleep for the duration of the operation. A breathing tube will be temporarily inserted through your mouth.
Through your mouth. The video said through your mouth. So the intubation usually, whether through your mouth or through your nose. What would you prepare in this operation? Or through the thoracic. Yes? Okay, so the better is not through the mouth. They usually put it through the nose. Okay? Nasal route for intubation. Okay? For the breathing. It's much better than...
And into your throat to help you breathe during the operation. Tonsillectomies and adenoidectomies are rarely done under local anesthesia in adults and never in children. During your tonsillectomy, your surgeon will use a special retractor to hold your mouth open and a tongue depressor to ensure an unobstructed view of your tonsils. Your surgeon will grasp each tonsil one at a time with tonsil forceps. Cut it away from the surrounding tissue.
Now this procedure is new kind, we call it electrocautery. There is an electric current passing. This electric current will produce heat. This heat will cauter between tissue. The same principle. You use a small piece, okay? This is the electrocautery. So as you cut at the same time. Okay? So there is no bleeding. Okay? You ligate all the tissue and you make sure it's one and the same. Okay?
And remove it with a snare or a tonsil guillotine clamp. Electrocauterization or clamps and ties will stop any bleeding at the site where the tonsils were removed. This area generally heals naturally without stitches. The procedure for an adenoidectomy is very similar to that for a tonsillectomy. Both procedures can generally be done in 20 to 60 minutes. After the operation, you will be taken to a recovery room until the effects of the anesthesia wear off, which usually takes about 8 to 10 hours. It is not unusual for tonsillectomy patients to go home the same day as the procedure.
Okay. This is an electrocautery tonsillectomy procedure. Here you can see. So the right one has been already removed. Now the surgeon is holding the tonsil with his forceps and using an electrocautery instrument, as you see. And you see he's cautery. As he cuts ligates at the same time. Okay? So very easy, simple procedure. This is an indication that the tissue is burned. Okay? And a burned tissue. You can see some reddish muscle fibers here. Which muscle is this? This is the tonsillar bit, guys. Which muscle? The superior constrictor fibers, okay? Fibers of superior constrictor. And if you look carefully, you can see that, or in a closer view, the orientation is going more or less horizontal. And that's how tonsillectomy done. Okay? How long does this take him? A few minutes, okay? Around less than 2 minutes, okay? You see how simple the procedure? And that's why now there is kind of exaggeration in this kind of operation, okay? Just for financial gain, okay? So anyone he complains, okay, let's go and do tonsillectomy. Laryngopharynx, the lowest part of the pharynx, it extends from the epiglottis, as you see here, to cricoid cartilage, base of the cricoid cartilage, really behind the larynx. This is the larynx here, and this space behind is all the laryngopharynx. It's located at the vertebral level of 4, 5, 6. What's happened after 6? Esophagus. Okay? The same for the larynx. Look, larynx extends from C4, 5, 6. At 6, the larynx anteriorly will become the trachea. Okay? It's lined by which kind of epithelium here now? Digestive epithelium. It's a digestive kind of epithelium, which is let's not say digestive, masticatory, let's say. It's not keratinized. Stratified squamous epithelium, non-keratinized, okay, which is the same kind of epithelium lining the esophagus, okay, non-keratinized, stratified squamous epithelium. The main thing here in the laryngopharynx, you will see a depression here at the sides of the larynx here within the laryngopharynx, a depression here and here, pear shape مثل حبة الإنجاز, فبيسموه piriform fossa. Piriform fossa. If you look in a real view, this is the larynx, this is the epiglottis, as you see, arytenoid cartilages. Okay, here's the base of the cricoid, here's the larynx end. All this space now behind is the laryngopharynx. Now, this is the depression which I told you about. There is the depression because here, this is one and this is the other one. This is the depression. We call it piriform fossa. It's a very important area. This is it here. You can see it here. This shadow, okay, in black. This is called piriform fossa. A small recess, gap or depression, okay, on each side of the laryngeal inlet. This is the entrance to the larynx at the sides within the laryngopharynx. It's bounded medially by the membrane. We call it aryepiglottic membrane. The quadrangular membrane of the larynx. You should know about it from the respiratory system. So medially, it is the aryepiglottic membrane. Laterally, it is the cartilage, the thyroid cartilage. Okay? So this fossa is bounded laterally by the thyroid cartilage and medially by the quadrangular or aryepiglottic membrane. Okay? This is called piriform fossa. What's the function? This fossa is very important because during the swallowing of sharp objects like fish bone, okay, sapir sama, okay, like the fish bone, if this fish bone can go all the way into the esophagus, it will harm what? The esophagus and the gastric epithelium and will produce several problems, okay. To avoid the swallowing, okay, of these objects, okay, foreign or sharp objects especially, they usually stuck in this area, okay, like the fish bone. Okay, so they stuck here and they don't go down into the esophagus. Okay, now something important here also, very important. In this region, I show you where in real view here. If you look in it, there is a very important nerve passing here. You see, just below the mucosa. This is very important nerve. This is called the internal laryngeal nerve. Okay, which is a branch from the vagus. Yes. So this is very important. Why? Because now when the fishbone is stuck here at the mucosa, hits the mucosa in the piriform fossa, okay, so it will produce what? An irritation for this mucosa. This irritation will produce a signal through the internal laryngeal nerve to the vagus. And now the vagus, which is responsible for the contraction of the constrictor muscles, okay, it will produce an action, but in an inverted way. Instead of contraction, I told you swallowing is the successive contraction of superior, middle, and inferior. Now, when the fish bones cannot go because of the presence of this recess, it will stuck in this recess. It will irritate the mucosa. Internal laryngeal will stimulate the vagus, and by return, the vagus will stimulate the constrictor muscles to contract in an inverted way. Inferior, middle, then superior. Which called gag reflex. If you heard about it, this is what we call it usually gag reflex. Okay, so the gag reflex is kind of what? Contraction of the pharyngeal musculature in an inverted way. Okay, why it happened? So that we can get rid of this fishbone back again to the outside. Okay, clear? What's the clinical significance here? So that's why piriform fossa is important. Okay. It contains under its mucosa the internal laryngeal nerve. Any object stuck here will produce a gag reflex, so you can throw things out. في حتى برات بالاوروفارينكس إذا بتشوفوا خصوصا الدنتست أكثر شيء بيعانوا منها لما بأخذوا impressions. Okay, but sometimes in some persons when you put your finger into his mouth, he tries to vomit. Okay, it's not a vomiting, it's a gag reflex. Because of irritation of this mucosa, usually stimulates the vagus for inverted contraction of the constrictor muscles, producing the gag reflex. Innervation of the pharynx, very simple. The innervation of the pharynx, نفس الانرvation that the structures continue with. يعني النازopharynx behind the nose. شو السنسوري innervation للنوز؟ olfactory special. أنا بحكي general sensation. olfactory smell. الميوكوزا الريسبيراتوري epithelium. maxillary nerve. Maxillary nerve from the trigeminal. Okay, so here it will be the maxillary nerve from trigeminal. In oropharynx, the glossopharyngeal. إذا سمعتوا فيه العصب التاسع, the ninth cranial nerve, اللي هو نفسه اللي بيغذي posterior third of the tongue. The posterior third of the tongue is located in the oropharynx, so it makes sense. In the laryngopharynx, the nerve that responsible for the larynx, شو هو? Vagus. So in the laryngopharynx, it's the vagus. So V2 maxillary nerve, oropharynx, glossopharyngeal, laryngopharynx, the vagus. The motor innervation, all muscles of the pharynx. شوفوا دائما في exception. في البلد في واحدة exception. في الtongue في واحدة exception muscle. Here the same. All muscles of the pharynx are innervated by vagus nerve via pharyngeal plexus, except one muscle, stylopharyngeus. It's innervated by حكيناها المرة الماضية. Glossopharyngeal. Yes. Last thing to speak in the pharynx in general, Valdire's ring. حكينا عنها لكن حاجات راح اشرح لكم اياها. Now when you look here, there is the nasal openings and the oral opening, where foreign structures can easily get into your body. So you need to perform a first line of defense, we call it. The first line of defense is represented in your body by the tonsils in the pharynx. Okay? These tonsils should surround these openings, nasal and oral openings. So that's why in the nasopharynx first you will see the pharyngeal tonsil above and two tubal tonsils at the side, behind the nasal openings. Now if you go to the pharynx behind the oral cavity, you will see two palatine tonsils on the lateral wall of oropharynx and the lingual tonsil in the floor of the oropharynx. So it's what? It's a hexagon ring, حلقة سداسية. Pharyngeal tonsil above in the nasopharynx, tubal tonsils in the walls of nasopharynx, palatine tonsils in the walls of oropharynx, and the lingual tonsil. So they provide a hexagonal ring. Okay, this is called Waldeyer's tonsillar ring. Henrik von Waldeyer described it, and it's represented by, as I told you, pharyngeal tonsil. It's single, يعني وحدة. موجودة وين؟ Roof of tubals وينهم؟ Nasopharynx, palatines, in the floor of. This is the first line of defense. Okay, the Waldeyer's ring. Esophagus, last thing to speak in this part. It's a muscular tube. Okay, عضلي. Okay, أنبوب عضلي. That lies posterior to the trachea. Remember always, respiratory system anterior, digestive system posterior. Larynx وراء الفارynx. Trachea وراها esophagus. So the esophagus is a muscular tube that lies posterior to the trachea and extends from the C6 into the stomach at the level of T11. Okay, to the level of T11. It enters the stomach through cardiac orifice at the level of T11. Okay, the esophageal opening in the diaphragm is located at the level of T10. T10. Okay, at the level of T10. So it's around 25 centimeters in length, depends. It passes through the esophageal opening of the diaphragm at the vertebral هيها مكتوبة at the level of T10. Okay? بعد T10 بنزل على stomach at the level of T11. Okay? It transports food into the stomach. Now, before we get in other lectures, أنا حبيت أحط لكم شوي على histology to review. When we speak about now the histology of the GI, from esophagus until the anal canal. Okay? يعني esophagus, stomach, small intestine, large intestine, they have the basic structure of 4 layers, okay, in histology, these muscular tubes, okay. Basic structure, بس بيختلف حسب ايش الفانكشن المطلوبة. So sometimes there's a characteristic features. بعض الستركتشرز فيها glands أكثر، بعض الستركتشرز فيها muscles أكثر. بس in general when we speak, we need 4 layers in any of the GI tract as you pass, okay. In the alimentary canal, histologically, it's made up of 4 main layers. The first layer, which is covered by the epithelium from inner, okay, to the outside, from inside to the outside, the epithelial lining. This is called the mucosa. Now, when you put cells beside each other, when I put these cells beside each other, epithelial lining, okay, كيف بدي أخليها ترتبط مع بعضها? If there is nothing to hold it together, okay, they can easily slush or slough away, okay? So to keep it together, I put a membrane under, a connective tissue membrane, okay, and put them on it. So now the cells are stuck to each other by a basal, okay, membrane, okay? That's why we need this basal membrane. So below you will find something called lamina صفيحة, lamina propria, proper lamina, صفيحة الرئيسية in the mucosa, because you need it so that I can put these cells over it, okay, to hold them together. That's why we need something called lamina propria. So its mucosa usually is made up of epithelium, and below the epithelium always there is something called lamina propria, the proper lamina, okay, the lamina propria. This is the mucosa. However, the main part is the epithelium. طبعا احنا اللامينا propria مش هتمسك السيلز مع بعض. The epithelial lining now in the esophagus is yes, masticatory اللي هو stratified squamous non-keratinized. لما بدخل على الستومك شوفوا بتغير بصير ايش؟ digestive one, simple columnar epithelium, okay? لما يدخل على الانتستين بصير absorptive بده يمتص، تغير خصائصه بس شكله structure the same, simple columnar epithelium, okay? So in the small intestine, large intestine or stomach, it's simple columnar epithelium. Now at the end of the small intestine or the large intestine, لما بيجي على الريكتم, okay, and in the anal canal now, it becomes, cells begin to get shorter, so that they become more cuboidal. So the upper part of anal canal, simple cuboidal, okay. Then after they get behind the pectinate line, okay, they become again stratified squamous, non-keratinized in the lower part of anal canal. Then to the skin, stratified squamous, keratinized. So in the esophagus, stratified squamous, non-keratinized. في الستومك, small intestine, large intestine, simple columnar. في الأبر بارت اوف انال كانال سمبل كيوبويدال. lower part of anal canal stratified squamous non-keratinized. بعد الانال كانال stratified squamous keratinized. Good. That's for the mucosa. Now below the mucosa there is another important layer. It's a layer of connective tissue, dense irregular. تعرفوا شو يعني dense irregular connective tissue? The fibers are going in different directions. This is called the area below the mucosa, the submucosa layer. This is very important area. Why? We need the submucosa because here you will have the blood vessels passing, which we need them, the vital organs, the van. أي structure to become vital عشان تكون عايش حي, you need the van. الفين الصرف الصحي, sewer system, صح? You need the artery, okay, المي, and you need the electricity, الكهرباء, النيرف. So these the neurovascular bundle usually passing in the submucosa. That's why we need submucosa, okay? فصار عندي mucosa, الepithelial lining, submucosa for the vasculature. Then there is the layer which I needed ليش؟ عشان تتحكم بالmovements, okay? الموفمنتس, البريستالتيك movements in the GI اللي هي الماسكولاريس externa بسميها, okay? The muscularis layer or muscularis externa. Muscularis externa in the GI in general, بس بتختلف sometimes, متكونة من two layers of smooth muscles. Smooth muscles, تمام؟ دائما الهولو tubes in your body smooth muscles, okay? These two layers, inner usually circular. لو هذا التيوب بتكون circular حوالينه, okay? الأوتر layer مشان تقويها بتكون إيش؟ longitudinal على طول التيوب, okay? So there are two layers, inner circular, outer longitudinal. When I have this cross section now, look, these fibers going circular to complete the circle. These fibers here are bundles, you see them? Why they are like this? Because they are going in columns, longitudinal, okay? So inner circular, outer longitudinal layer, okay? In generally speaking now. So we have muscularis externa, inner circular, outer longitudinal, and after that we need the covering, the protection. The covering بيتم عن طريق ايش؟ areolar connective tissue اللي هو عادة بنسميه adventitia. Okay, here, very difficult to be seen. We call it the adventitia. When this adventitia become in touch with some smooth mesothelial cells, بنسميها البريتونيوم, بصير اسمها السيروزا. لأنها بتصير ملسي أكثر. Okay, I call it the serosa. So four main layers: mucosa, submucosa. The mucosa عرفنا lining, submucosa for neurovascular bundles, muscularis for movement, and then the protection by adventitia. Okay. These are the four main layers in histology in the GI. In histology lectures, we will speak in more details about the differentiation between them. Now, one of the specific differentiations, for example, in the esophagus, اللي هي muscularis externa. Muscularis externa هون احنا بنعرف inner circular or outer longitudinal. Now, if you take the esophagus, in the upper third of esophagus, okay, the muscularis externa هي عادة في الGI كلها smooth muscle. The exception is here. In the upper third, it's a striated muscle. Mostly, there is some smooth fibers, but mostly striated muscle. Okay? يعني more close to the shape of a skeletal muscle. Okay? It's a striated muscle. In the middle third, it's mixed. عادة في middle third of esophagus, inner circular بتكون striated, والouter بتكون إيش؟ smooth. أو العكس، تأكدوا منها. العكس زي ما هو هون, as I see. Inner is smooth muscle, the outer here is skeletal, longitudinal. In the inferior part now, completely smooth muscle. Okay, so the upper third is طبعا skeletal غيروا لي حطوا striated. Okay, هذا الحياة text book كاتبه skeletal. It should be named striated, not skeletal. Skeletal is attached to bone, to movement مثل الbiceps. This is striated, نفس structure of the skeletal, but it has no bony attachment. So, inner circular, outer longitudinal, في upper third striated mostly, في middle third mixed, smooth striated, في lower third completely smooth. Okay? Muscle.